morning everyone. Today we will do abdominal examination in a 7-year-old child, Azan, who is lying comfortably in front of me. Abdominal examination is relatively easier to do. The components are inspection, palpation, percussion and auscultation. But many a times things are being missed because observation during inspection may not be that optimal. Let's proceed for the examination. I will sanitize my hands before touching my patient and will try to take consent from the patient. Azan, अस्सलाम वालेकुम, क्या हाल है आपका? मैं आपके पेट का मुआयना करूँगी, कहीं दर्द तो नहीं है, कोई प्रॉब्लम तो नहीं है. Before I touch my patient, I need to make sure that patient is comfortable and he is not having pain anywhere in the abdomen. Let's have a look at the abdomen. For that, we actually need to bend at the liver of patient to see is there any visible pulsation, any bulge or scar mark, pigmentation or stria. Similarly, I'll go to foot end of the patient. From the foot end, we need to bend at the level of patient to see umbilicus is central, which is inverted. There is a hyperpigmented area on the left flank, which is around 1 into 1.5 centimeter. Abdomen is moving symmetrically with respiration. There is no obvious bulge, scar mark or any pulsation. So the next step should be auscultation of the abdomen, because when there is a gut obstruction, the gut sounds would be sluggish or they may be absent in sphere obstruction. Cutting down this auscultation part just after the inspection, for the reason being that once we will percuss or palpate, gut would get stimulated and the actual picture may get masked. We will be using diaphragm of the stethoscope and we need to ideally listen for 2 minutes, gently putting it in the right iliac fossa, then again at right lumbar and hypochondric region. Similarly, we need to auscultate on the left side and then at left iliac fossa. If we do not hear any gut sound in 2 minutes, this would be a case of intestinal obstruction. The next very important step would be to palpate. For this, there are 2 parts. One is superficial palpation. Purpose of superficial palpation is to elicit any tenderness if there is in the abdomen. Number 2, if any enlarged viscous or mass is there, that rough estimate can be made by superficial palpation. Ideally, this is an S-shaped manner palpation which start from the left iliac fossa and then proceed accordingly. My hands should be warm. So I will start from the left iliac fossa very gently, looking at the patient so that if he feels any pain, I need to know about that. Going to epigastrium, right lumbar area, right iliac and then proceeding to right hypochondric region. For deep palpation, either we start from the liver, which is generally the case people do, or we can start from the spleen first and then proceed accordingly. We will ask the patient to raise his legs so that the abdominal muscle get relaxed further and that palpation become easier. Azan, you need to raise your legs and put it like this. So for palpation of the liver, our prime duty is to see where is the upper border of liver. So for ascertaining the level of upper border of liver, we will start from the second intercostal space and percuss it with the middle finger of right hand. Before percussion, the fingers of the left hand need to be little apart so that the sound does not get dampened. So we will make a very small mark just to see that it is the upper border, and then we will palpate for the lower border of the liver. For this, I will give command to my patient that you need to take a deep breath. As the liver is triangular in shape from the right lobe till left lobe, it moves upward. We have to keep our hand parallel to that direction of the lower edge of liver, and the radial aspect of index finger is the main palpating force. लंबा सांस लेना है आपने. We will keep palpating when the patient is taking deep breath. If the liver is enlarged, the margin should touch my hands. Then the next step would have been to elicit any tenderness, see the texture of liver, the firmness, and at the same time we need to palpate for the left lobe of liver. Next we will palpate for the spleen. Ideally we need to start from right iliac fossa. There are two options. Either we can start with the fingertips. The other option, which is more commonly used, index border of the right hand. I will ask him to breathe deeply. And as soon as he has taken a deep breath, the splenic border is now palpable. If spleen is minimally enlarged and barely touching the hands, or if the spleen is not yet palpable on palpation, the next step would be to ask the patient to turn to my side. At the same time, we will be supporting 9th to 11th space, and that pushing force will give us clear presentation of the spleen lower down below the rib cage. See. So 1.5 centimeter below the costal margin. And at the same time, I have been able to elicit whether this is tender or not. If spleen is relatively massively enlarged, palpate for the notch of the spleen, which is one of the confirmatory indicators that this is spleen and not kidney. So in this case, as it's only 1 to 1.5 centimeter enlarged, so palpation on the medial border is useless, as we will not be able to point out where the notch is. The next step is to palpate for the right and left kidney. The kidney is artery to peritoneal artery, where we have to push the kidney up, and the front hand will be just gently dipping down, while the main pushing force will be the hand on the lumbar area on the back side. I am going to palpate for the right kidney, pushing it up in the lumbar area and gently dipping down my right hand. The left kidney will be similarly palpated. Left hand at the lumbar area, pushing it up, and the front hand will be gently palpating. The next is bladder. So this is the only viscous which is being palpated with the left hand. As his bladder is empty, so I didn't feel upper border of the bladder in the abdomen. The next and final step would be, if any other mass of any origin is palpable, describe its size, shape, its tenderness, overlying skin, or in case any bruit on that mass, that can be auscultated. Next is how to elicit the abdominal fluid content. For this we have two tests. One is shifting dullness, the other one is fluid thrill. In this case, as we can see, umbilicus is central, it's not bulging, so probably there is no fluid in the peritoneal cavity. But if you find a slit-like umbilicus, or this umbilicus is everted and there is an abdominal distension, then definitely there would be ascites. To elicit shifting dullness, first ascertain that bladder is not there. For this we will start from the epigastric area, go down and come to suprapubic region and see that bladder is not percussible. Next thing would be start from the umbilicus or midline and go laterally and see is there any dullness anywhere on the pathway or at the extreme ends. There is no dullness anywhere. If there would have been dullness, the next step would be to ask the patient to turn to this side and wait for 30 seconds. The idea behind this 30-second wait is so that the fluid get gravitated or shift to the other side and that area become resonant, which was previously dull. If there is a marked abdominal distension and we are pretty sure that there is a fluid in the abdomen, we need to seek help from attendant or patient if cooperative can help us. अपने अपना हाथ जोड़ रखना है. On one hand, I'll put my hand, and on the contralateral side, I will click with my index finger very gently. If there was a free fluid excess in the abdomen, that fluid will splash and will touch my other hand. While having a look at the genitalia, the ideal way is to maintain the privacy of the patient and have a screen. Have a look at the back where We need to look at any scar mark, previously surgery, pigmentation, stria, myelomeningocele or spinum bifida. You may find a rash on the buttocks, and that can be seen from the back side. It was all about abdominal examination. If you have any queries or questions, you can put them in the drop box. Thank you.